A live look this morning in Kyiv, Ukraine, more than a month after the Russian invasion began there. Here's what we know so far. Thousands of soldiers on both sides have been killed since the fighting began on February 24th, and thousands more soldiers and citizens have been injured. Many of the injuries so severe we cannot show you the pictures, but there is one doctor here at the University of Kansas Health System, a surgeon and a soldier himself, making sure those hurt on the front lines get the medical care they need to survive. His story this morning on the Morning Medical Update. Good morning, everyone. It is March 24th. Thanks for joining us right here on Facebook, on YouTube, and on Twitter. Today, we will meet a man who spent 2 tours of duty in the Middle East caring for deployed service members. Now, orthopedic surgeon Dr. Matt Drake is helping treat soldiers injured on the front lines in Ukraine from all the way here at the University of Kansas Health System. Also, Chief Medical Officer Dr. Steve Stites is joining us, along with Dr. Deetra Ford. Get your questions sent in to us on YouTube, Facebook, and the Medical News Network. You can find links to all those right there on your screen. But first, let's get to Dr. Dana Hawkinson. He's our Medical Director of Infection Prevention and Control, joining us with our numbers. Good morning to you today.
Hi.
Hi.
Numbers are looking good, again, trending down. 11 active patients, 0 in the ICU, 0 on the ventilator, still 49 in that recovery period, a total of 60, but overall, the active infections are continuing to decrease, which is good. And I think we've talked about this briefly. We know that BA2 is now the predominant variant in the United States, but we haven't seen an increase in cases thus far, which is good. And more importantly, we haven't seen an increase in hospitalizations either.
You gotta like it. Yeah, no, I think it's good news. It would be great. We said a year ago we got down to 5 or even 3, I think, for a few hours in March, and so that it would be great to get down there. But it is absolutely the right trend. We like what we're seeing, and I'm with you, Hawkeye. I don't think the BA2 variant is going to hit us that hard, in part because of reasonable vaccination rate. Lots of folks have had boosters. Lots of people have had COVID, and Omicron and the BA1 and BA2 are so close together in time. I think host immunity, natural immunity left over from a BA1 infection will help sustain you through the BA2. I think there has been a pretty good, some good information coming out in the last few days. First, we know vaccination for those 50 and over for a second booster shot, so a total, if you're on Moderna or Pfizer, of 4 shots. Yeah. Second of all, very clear recommendation now from the FDA that if you've had the J&J shot and you've had a booster, you need to switch to an mRNA because you're going to have better infection, better prevention. I think that's important. And the data we've talked about before, which came out of Brazil, has now been peer-reviewed, fully published. Wow. Ivermectin, no help in COVID-19, Hawk.
Yeah, no, I think this is good. I think this is one more brick in that wall. We've had a couple other well-done, randomly controlled trials. The ITAC one was one of those. That was the trial name that was published in JAMA Internal Medicine recently, I believe, that showed no improvement or no risk reduction for progression to hospitalization or severe disease in those people who have COVID-19 and are taking ivermectin. This is one of the largest trials, and we should mention this trial also looked at other drugs. This looked at, I think, metformin. This looked at fluvoxamine. This was the large trial that saw that there was maybe some benefit for the fluvoxamine for reduced rates of going to the hospital, but I think we are all happy that this was finally peer-reviewed, so it went through strict critiques, and ultimately what it showed was that taking ivermectin for COVID-19 did not reduce your risk of developing severe disease or having to go to the hospital. Again, one more brick in the wall for trying to define standards of therapy. What are the best therapies? The most important thing, Steve, like we always said, vaccination helps keep you out of the hospital. This is one more thing that we can use to help define outpatient treatments to help keep you out of the hospital. We know monoclonal antibodies work. We know Paxlovid works. This is one thing now that has been shown through multiple studies, and even that meta-analysis that when you take out those biased results, those falsified results, showed that there was no benefit of ivermectin as well. So hopefully the NIH will review all of this and maybe we'll put out some an update to their treatment guidelines as well.
I think some people will say, well, gosh, the studies you guys always quote about ivermectin are in Malaysia, now in Brazil, and is that really smart? Is that, and that, that first of all, it's it's hard to hear that because studies come from all over the world all the time in medical science. And second of all, the peer review process is exactly what's there to try and ferret out. They know the investigators. They've all been involved in these trials. They all know each other. They work hard to make sure the science is strong. So I think whether it came out of Malaysia, it came out of Brazil, it came out of Germany, or it came out of the United States, this is all really important data. And what we know is when you do these large trials and it's been peer reviewed, that is actually the best information. And then you get folks out there say, well, you're on the take from the drug companies.
Yeah.
It's just, I can't tell you how offensive that can be, because what happens is these folks are spending their entire lives on it. They're not getting financial gain from it. They're just trying to tell us the truth about what they've found in their research. And finally, there is the large Ivermectin trial. I think it's still ongoing in the U.S. We have been a participant in that trial. We've had Dr. Mario Castro on here a few weeks ago saying, hey, here's the number to recruit into it. And so if you want to be a part of that trial, we can find evidence around it. But everything we see so far is that though there were originally case reports, as you look at large groups of folks and you study whether or not ivermectin makes a difference, when you have one group getting it and another group getting placebo, the group getting placebo does just as well as the group getting ivermectin, which says there's no real treatment benefit. So I think if you follow the science, you'd say the science says no.
Yeah, I think that's true. I think we can all have our hypotheses, and we want to put those hypotheses to the test. And this was one that asked that specific question. We have an answer now. We have a consistent answer from a couple different well-done large trials. And I think if you keep making excuses, you just keep looking for other reasons. But then that starts to become an indictment on the full concept of evidence-based medicine and all the trials that we've done for everything from antibiotics to chemotherapies. And you can't just cherry pick this one therapy or this one topic, because then once you start doing that, you have to include all the other trials, all the other drugs that have been done in the same exact way.
Right, so that means you wouldn't necessarily want to have your interventional procedure done for your heart attack, or be treated for the stroke, or be treated for your, other injuries, because that may not work, and it may be some of the therapy that no one else has been able to work for. I mean, it's a very difficult loop when you get into it about how you're going to think through the problem of it. And I think the key is that we're trying to offer the best things that we know that clearly work and that we've watched work, even in our own hospital, right? We're like remdesivir, like steroids, and as you pointed out in the outpatient side, like the monoclonal antibodies, which have been remarkable.
And I think to that point, Steve, we've always talked about why is the vaccine so important? Because it's the safest way to immunity to reduce your risk of hospitalization. If there was another drug that was widely available, that was generic, cheaper, we would want to do that to keep you out of the hospital. We know Paxlovid works. We know that's not widely available right now. It is a new drug. We also know monoclonal antibodies work. All of those things to keep you out of the hospital. So we are looking for the best things, the safest things, and most important, the things that work to keep you out of the hospital. Right now, the information that is presented in the peer-reviewed, well-done trials does not support the use of ivermectin for doing that.
Today is the last 2 days COVID-19 testing sites in Johnson County will be open. 2 locations, one at Johnson County Community College in Overland Park and the Church of the Resurrection in Leawood. They will stop offering testing tonight at 6. The Johnson County Health Department will still offer drive-through testing every Wednesday at its building in Olathe. In headlines this morning, die-hard actor Bruce Willis has announced he is stepping away from his acting career due to a debilitating disorder. It is called aphasia, and it affects a person's ability to express and understand written and spoken words, basically robbing you of the ability to communicate. Willis and his family made this statement yesterday via social media. So it left a lot of people asking, what is aphasia? And is there a treatment or a cure? We are joined this morning by Dr. Deetra Ford. She's a neurologist here at the health system. Dr. Ford, thank you so much for being with us today to kind of help us better understand exactly what aphasia is and how it can develop. Help us understand.
Absolutely. So aphasia can be multiple different things to different people depending on what's affected. So we look at people who are slowing down in their speech, pausing, having trouble finding words, misspeaking words, replacing words in a sentence, trying to talk around a word. It's difficult for a lot of people because they'll start conversing less. And so sometimes it's hard to figure out if it's aphasia. Are they having hearing loss? Are they depressed? Or is it a little bit of all of those things? And so that's really what we start to see. Some people will also have trouble with reading and writing words as well, or even identifying what a word means. And so there are, again, different types of that.
So this is something that maybe someone you live with, your spouse, your kids might notice at home. almost like self-diagnosed.
Absolutely. Usually people come, by the time they get to us, it's usually because family is saying, they're really having trouble finding words. They're not able to figure out what the toaster does. They can't figure out what a toaster is. And so we start looking for causes at that point. Is there something that's triggered this? Is this normal aging? Because obviously we all start to find some word finding difficulty as we get older as well. And so it's really trying to discern, is this a medical condition or is this normal aging?
So how does this differ then from dementia or Alzheimer's?
Great question. So it can be different and it can be part of a spectrum. So in terms of causes, we worry about obviously stroke if it's acute onset, meaning it happened really suddenly. We worry about tumors, especially if it comes on slowly or even more quickly within a matter of weeks. We worry about infections. And then sometimes after a traumatic brain injury, people can have aphasia. But the most common thing we would see in someone who we're worried about for dementia would be a slow progressive process. So there are different types that are associated with Alzheimer's disease, which is more forgetting words, or you have problems with speaking the words or putting sentences together and making things make sense. And that's more along the line of something called frontotemporal dementia, which is a very rare cause of dementia, but we're finding more and more patients with that as well.
Dr. Ford, do you think, is aphasia something that occurs singularly by itself, or is it really almost always associated with another disease process?
I would say most of the time it's associated with another process or something else going on. It is rare that a stroke causes only aphasia. Typically there are some other symptoms. It's rare that a tumor would cause only aphasia. So usually we're seeing some other things as well.
And so I remember back from my days in medical school, which were approximately yesterday, it's very recent, the speech is one of the highest orders of processing and mental acuity that we have to do, right? That's one of the hardest things our brain is doing, to hear sounds, translate the meaning, and then put out something meaningful back, which I struggle with on a daily basis as it is. But so it's often a sign there's other issues going on in the brain.
Yeah, absolutely. And that's why we do a workup. And so if someone's having some of those issues, we do recommend getting a referral to a neurologist. And oftentimes we'll do a workup in the office with some question and answer, have you do different naming tests, repeating tests, some pictures and spelling, and just some things that help us determine which type of speech issue you're having. And then we go as far as doing some lab work and oftentimes even an MRI or even a PET scan, depending on what our suspicions are at that point.
Dr.
But
Ford?
Absolutely. Oh, I'm sorry. Go ahead.
Oh, no, please finish.
It just depends on, again, those other symptoms going on, like Dr. Stites mentioned.
Has COVID had an impact on aphasia?
Interestingly, what we've heard the most is brain fog with this COVID pandemic. And so just yesterday, in fact, I saw someone who was having some trouble with word finding and brain fog that had COVID and was having some long haul symptoms. And so I do think it's possible. We've had a lot of people, including patients like this, that work with speech therapy to try to help with cues, both visual and audio, that we can help them try to work on that aphasia portion.
So one other thing, just to think, so when I was younger, I could talk almost as fast as Lin-Manuel Miranda, perhaps not quite that, but pretty darn fast. And as I've gotten older, things do slow down a little bit. How much of what that is normal as you get into your 60s and 70s, and how much of that is abnormal? Where do you draw the line between normal and abnormal? When do you get concerned?
Absolutely. So normal would be, I forgot someone's name. I'm struggling with figuring out what something is that I haven't seen for a long time. But abnormal is when it starts to affect your daily activities. It starts to affect your job. You're no longer able to put together a presentation for work. You're no longer able to speak in a conference such as this. You're no longer able to have a conversation with your colleagues without being nervous or anxious that you're going to forget a word, or people start noticing it a lot more. Those are the times where we start to worry a little bit more that something else is going on. And we do definitely see word finding difficulty as we get older, but there's a definite difference when something else is going on, because usually there starts to become some other memory issues, some mood issues. People start to maybe get slower in general in their overall movements. So there are a lot of other things that typically happen when it's actually due to one of these other neurologic causes other than just normal aging. But yes, our brain atrophies, the connections slow down, all those things happen as we get older, and I've yet to find the fountain of youth.
Yeah, I tell you, my wife might sometimes think my brain's atrophied. I may not. Maybe she's blaming some of my actions
You have
on
male
that.
brain.
I have male brain. Thanks for that, Jess.
You're welcome. That's my technical doctor term.
There we go.
That's all right.
That's a little mansplaining right there. Oh, wait a minute.
Oh, wait a minute. Okay. Question, though, Dr. Ford. Bruce Willis is 67 years old. He says he's stepping away from his acting career. Is this something that he, with proper treatment, would be able to step back into in time? Or does he have to hang it up for good?
Yeah, so obviously I don't know his case. I'm not his treating physician, but normally when we have aphasia, it's not something that gets a lot better when it's due to a neurodegenerative process, stroke, tumor. If it's due to a stroke, we can do some rehab and get some speech back. But if it's due to a neurodegenerative process, which I will say in the 50 to 70 range, it is the most common time frame for us to see this develop. Unfortunately, at this time, there is no treatment in terms of cure. All the treatments are more supportive with speech therapy, sign language, language boards, other ways to communicate.
The term neurodegenerative, it could be like a vascular, like you're not getting enough blood flow, or Alzheimer's, or other issues of cognition. So that's a big, broad category, and it's kind of one of the diseases I think, Dr. Ford, it's fair to say you really don't want to have.
Absolutely not. Absolutely
Dr. Ford?
not. There's no thoughts.
I'd like you to stick around. We're going to get on to our topic today, but it's my understanding that your mother is from Ukraine. Your aunt is currently in Ukraine. You were talking with her daily. I want to catch up with you. If you could just stick around, I'd like to ask you a few questions here in just a moment.
Absolutely.
Great. Thank you so much. Okay. Moving on with our topic this morning, broken bones, gunshot wounds, IED, explosion burns. Those are just some of the wounds that doctors in war zones like Ukraine deal with hour to hour. And unlike hospitals here in the U.S., they may not have access to the latest in medicine. So they make do with what they have. Over the past decade, combat medicine has improved considerably with an overhaul of everything from training to gear. Enlisted military training for the U.S. Armed Forces is located at the Medical Education and Training Campus at Fort Sam Houston, Texas. After completing the basic medical course, students go on to advanced training in tactical combat casualty care and learn a set of evidence-based best practice pre-hospital trauma care guidelines. Dr. Matt Drake is a surgeon here at the health system and joins us now to talk more about what he is doing here in Kansas to helping those others in Ukraine. Dr. Drake, good morning and welcome.
Good morning. Thank you.
Thank you. First of all, thank you for your service. I know that you have served our country, and we appreciate that very much.
Thank you.
So we have this large veteran population here in the metro. Many of us, we have never experienced being in a war zone. You did those two tours of duty in the Middle East. Just talk to us a little bit about what that was like, and then we'll talk about what you're doing to help those in Ukraine.
Sure. Yes, so I got deployed to Iraq twice when I was in the military, and these were very unique experiences. The first time I was there, I was assigned to what's called a combat support hospital, which is more of a fixed facility where we would care for injured U.S. soldiers and get them stabilized and get them out and get them on their way home. We would also care for injured local nationals, sometimes the bad guys who we captured. And those folks we would treat more definitively. And the second time I went, I was with a forward surgical team, which is essentially a very small unit attached to a forward force where we just do damage control surgery. So it was a team of 3 surgeons and some nurses and some medics, and we were essentially operating out of a garage in the middle of nowhere.
I want to show some photos, if we could pull those up, of you doing your work there. Yeah, you kind of explained it, but what is it like to go without when you're trying to help people do what you do?
It's hard. You can't apply the same standard of care that you have here in the States. You may not have the same equipment. You may not have the personnel that have the experience that you're used to having. Everybody's in a different role and everybody's stressed. You don't have the same facilities. In the fixed hospital that I was at in Baghdad, we were essentially functioning out of trailers. And so you would kind of have to dust off things in the operating room before getting to work.
Dr.
It's a little
Stites?
different. So just, we've had I've done some medical missions and things like that, but nothing with what you have done. Is there a higher rate of infection, complications, or is it sometimes amazing how well people do?
One thing we noticed, the infection rate among people who are from the Middle East was low. I think if you survive childhood in that part of the world, you're made of pretty strong stuff. But the infection rate among Americans was very high. When we would deal with blast injuries, we had to learn to alter the way we took care of them because you can't go real fast with wounds, and infections were definitely a problem.
Isn't it fascinating that it would be different in such different populations?
Mm-hmm.
And I think you're right. There's got to be something about having been raised in an environment and what you're used to, and then the bacteria or whatever that you're exposed to. So.
Right.
So, Dr. Drake, you've been a hand surgeon for 14 years, working here at hospitals
Mm-hmm.
here at home, but also helping those overseas in a time of war. So this past weekend, I know a lot of people are always saying, how can I help those in Ukraine? And you just did just that. You participated in a webinar, a web seminar, to help hand surgeons do their job on the battlefield. Tell us about it.
Sure. So the president of the Ukraine Hand Society reached out to the American Hand Society and asked for some help. And they got together a webinar very quickly featuring some of the members of the Hand Society who had military experience and had done some of this stuff before. And so 9 of us got together and basically gave some lectures online, and 60 or so hand surgeons from Ukraine were on the call. And we basically each kind of took a topic and showed some cases and lessons learned, and hopefully provided them some help because they're dealing with things they may not have dealt with before. And fortunately or unfortunately, a lot of us in the U.S. have some experience with this.
The cost of war, it just brings home. I was, when people showed me the slides you were going to use and the slides setting the injuries, we went through them and said, those are tough, and the things you have to show and the things you have to talk about, that it makes it very, very real.
Mm-hmm. Absolutely. It's not stuff that you want to be familiar with, but that's the world.
And unfortunately, it's got to be difficult, especially for those trying to find a place to operate in Ukraine and constructing field hospitals, et cetera, to make sure they triage and get people taken care of as best they can. Talk to us a little bit about what's it like, do you think, on the ground right now in Ukraine for the medical people?
Oh, I can't even imagine. I've been in scenarios over in the Middle East where, we're dealing with a mass casualty situation. So we've got several injured people coming in at one time. And that's stressful enough with limited resources. But we didn't have the stress of worrying that your family's being rocketed at that very moment. And that, throw that on top of it, I just can't imagine how overwhelming it is for the population there and the surgeons trying to do their jobs.
In a time of war, is it common that people target hospitals?
Not supposed to. I mean, there are rules against that, but I don't know they're always followed.
So how do you use this 14 years to translate from here, where we have access to everything, there on the battlefield?
I've had a very unique and blessed experience to be in the military and learn these lessons, and I apply them on a daily basis. You see civilian injuries and trauma, and they're always kind of back of my mind, remembering the lessons that I've learned from dealing with other things. So it's useful. It's there. I mean, I'm happy to have that experience.
What other steps are being taken to help bring better care or medical care to the field?
We study it. For the past 15 plus years, the American Academy of Orthopedic Surgeons has put on a symposium every year called the Extremity War Injury Symposium, where academic military researchers present what we've learned. And that filters down through our training programs, like you mentioned in San Antonio. We train and just try to learn from the best we can from our experiences.
So these folks that you were talking with through this webinar, they're dealing with hand injuries, but people come back with all sorts of catastrophic injuries and PTSD. So how do you help prepare them for life past this?
Sure. It's hard. I mean, these injuries for young soldiers are just devastating. They go from being a normal, healthy person to not the same person anymore. And early on, the best strategy is to try to help them think about what's in front of them now. Don't think about 5 years from now, but think about what's going to happen in the next few days or the next few weeks. And then another strategy that has been helpful is to have injured folks who are further along the rehab process meet with them. So, a guy that just got injured 2 weeks ago who's lost 2 limbs, to have someone was injured 3 years ago come speak with him and talk to him about his recovery process.
That's got to be comforting.
They go through a very difficult grieving process, and it's not just the injured person; it's their family members, it's their medical providers. It affects everybody.
It does. Dr. Seitz, you were asking about what life is like on the ground there for people in the medical field. And I want to talk with Dr. Deetra Ford, who shared with us before the show started that her aunt is there now and that you speak with her daily. Could you tell us a little bit about what you're hearing about civilian life there right now?
Sure. So luckily, my aunt is in the western part of the country, closer to the border. A little bit, lots of people have heard about Lviv, so we kind of put that in perspective, about 2 hours southeast of that. Or southwest of that. And so she is in a place where, she hears the air raid sirens, but luckily has not been bombed. Very thankful for that at this point. I know they've had a few more closer to Lviv now, which has been a little scarier for everyone. The main thing that she's been dealing with and their community has been dealing with is the refugees, the people trying to leave the country. And since she is closer to the border, a lot of people are coming to that city to continue across. And what's difficult about that is food and supplies, medical supplies and food. And so they're really struggling to keep those people fed, clothed, warm, and medications and things to them. And so a lot of the folks in her town have opened up their homes to folks as they're traveling through.
Emotionally, how is she dealing with this? I mean, she might be semi-safe from harm, but these are her people. How is she emotionally handling this?
It's been hard. It's been hard for our family too. My mom and one of my other aunts are here, and we actually have been trying to get back there for 3 years. The pandemic has kept us away for 2. And I say thankfully, my grandfather died in January, and so my aunt had been there taking care of him. And so, emotionally, we're all kind of traumatized by that and thinking, we're going to go this summer and help clean up the house and do those things. So that in itself has been emotionally hard. And then all the friends that are still there for my family and knowing that they're having to leave the country or move or be scared and unsafe. It's been emotionally draining, honestly. It's been a stressful last few months for our family. And the good news is we do hope she remains safe where she is. And, trying to get out of the country, she is a U.S. citizen as well. And, absolutely she could try to get out, but then there would be nothing left of the home because the people are going into the homes, obviously, to try to get to their own safety. So it's a tough position.
Yeah, and she's being able to help people there. So, wow, we appreciate her doing that. We appreciate you sharing that part of the story and that perspective. Dr. Drake, how has COVID stood up when we talk about COVID every day and how catastrophic that has been in our world here? How does that scale up when we're talking about a war and what these folks are going through?
Yeah, I think it definitely pushes it down in terms of priority. When that wasn't really a topic we talked about on the webinar.
Mm-hmm. It didn't even come up.
Not once.
Not once.
No.
Not once. Dr. Seitz, anything to add before we get to community questions?
I'm always impressed by resilience, whether it's in a pandemic or when it's war. But when you hear the words from Dr. Ford and Dr. Drake, I think what you realize is that resilience does have its limits, and the devastation from a pandemic, the devastation from war, these are trying times for all of us. And I think what we try to do is find hope in humanity and faith. And I think we said that before, the intersection of faith, hope, and science is what delivers through a pandemic. And I think as people, we thank Dr. Drake for the great work you've done, both serving your country and to help bring hope to those in Ukraine. Dr. Ford, to your family, trying to bring hope. Because between hope and faith, hopefully we can find a way out of the darkness, and I think that's what we have to do.
Let's get to some community questions. So Isaac has a question, and I think you touched on it, Dr. Ford, earlier, but could you just quickly go over what differentiates aphasia from Alzheimer's and dementia?
Sure. So they can be one continuum. So aphasia can be part of Alzheimer's or frontotemporal dementia. So it all depends on what the underlying cause is. And so that's why we really encourage people to reach out to their doctors, see a neurologist, get that workup done if they have major concerns that something's progressing, because again, it really can be a continuum for a lot of folks.
All right, we have a question from Jean this morning. Why is BA2 causing such havoc in China if you feel it will not be a problem here? We got a few BA2 questions this morning.
I think that's a great question.
That's
You're saying
a
in
great
China and Hong Kong. I think the reality is that China and Hong Kong had a zero COVID policy. And so what happened was, as soon as somebody was diagnosed, they just, you went back into your home, you shut down, et cetera. They had a mass vaccination program. The Sinovac may or may not have been a great vaccine. But I think the real issue is that so many folks in China and in Hong Kong have never had COVID. And what you're seeing is the initial exposure. They would have had the same problem had the initial exposure occurred with the alpha wave, the delta wave, the first Omicron, and now BA2. And we would have the same problem if this was the first time we had been exposed. But because we've been through so many different variants in our population, and we have so many people who have been vaccinated with very effective vaccinations, especially the mRNA vaccines, we're going to be safer with the BA2 variant. That doesn't mean we're going to be safer from the next variant, but I think, Hawk, we're safer from that variant because we do have a lot of exposure.
Yeah, I think this is a multifaceted answer for sure. We have seen extremes on either end. China has gone to a zero COVID policy. We've seen what has happened, the lockdowns. We know what happened with the lockdowns in the United States, just with emotional and physical health with that. I can't imagine what's going on in China. We have seen, however, also what happens when you have a full open policy, as they did in Florida. And unfortunately, that leads to a lot of tragedy, a lot of morbidity, and a lot of mortality. We also have good vaccines here. We know that the vaccines in China currently are not as efficacious as they are with the mRNA vaccines or the Janssen or Johnson & Johnson vaccine as well. So there are issues there. There is also, if you talked about, there is not that natural immunity for people who have been infected because they just haven't been able to be out and spreading the disease. In addition, we know that in Hong Kong, for instance, China, we know that the elderly, the most vulnerable populations, are really not vaccinated. And this is, I think, they still have a lot of fear or trepidation, the elderly in particular, for getting vaccination, from what I've read in the mainstream media news outlet stories. So there are different, very many reasons for that. And unfortunately, we are seeing this now play out, especially in Hong Kong, but in other countries in Asia as well. And so I think it is bad. But again, a multifaceted answer having to do with vaccine immunity, which again we know is the safest way to immunity, but also, as you said, there's been lockdowns, there hasn't been a lot of spread, so there is that general population immunity that isn't there as well.
I think one other thing to remember is BA2 is the most transmissible of all the different variants since the start of this pandemic. What that means is it's really much easier to spread even than the original strain. Yeah. And so what's now happening is unless you are in complete lockdown, even if you are, this is so easy to spread that it will rapidly move through a population. And it's moving through a population that may have been vaccinated. I don't know all the vaccination status in China. I know the Sinovac was about 50% effective and less, even against the Alpha variant, which means it's going to be much less against Omicron and the BA2 variant. So I think it's probably a population that's relatively unprotected, under-vaccinated, and now has the most transmissible one of the variants. So that's going to be the recipe that will be that'll be difficult.
And I'd certainly like to continue to talk a little bit about the science, and just like to give a shout out to those T cells. We know that the vaccines we have continued to work. We know that the antibodies that are produced, we get very high antibody titers, but we know that these variants of the virus can evade those antibodies that we have, but we do have those T cells that we obtain from vaccine immunity and from infection and reinfection that continue to help reduce our progression to hospitalization. And so I think, we are thankful. We know that the vaccine companies are working on pivoted vaccines or pivoted spikes maybe to some of the variants. But right now I think we are fortunate in knowing that the vaccines that we do have, they do induce good B cell immunity, which creates the antibodies, but also they continue to have durable and effective T cell immunity, which really helps save us from hospitalization and severe disease.
I love that. A shout out to T cells.
Yeah.
Well
Shout out to
done.
T
That was
cells,
good.
man.
I was like, who's he going to give a shout out to?
I know.
That's
Shout out to T cells. Yes.
That's right. Thank them.
A couple of quick booster questions. You may have touched on them at the top of the show, but just go over these real quick. Ashley, regarding the J&J vaccine, if a person has had one mRNA booster, do they need a second?
So if you've had the J&J and you've had one mRNA, then now that if you're over the age of 50 and it's been at least 4 months since your last booster, you're recommended to get another booster. There's so much gray in that statement because if you had COVID in the meantime, it's going to change the story a little bit. So it's best you kind of talk to your primary care provider. But in general, I think you're seeing the FDA and the CDC move away from the J&J vaccine, Hawk.
Yeah, again, I think J&J, we know there was a preprint article that looked at Novavax, J&J, and the two mRNA vaccines that looked at their immune responses, T cells, B cells, what have you. They all function very well. They do create that immunity. But I think you're right, Steve, and it kind of is down to now individuals. I've gotten a lot of questions about boosters in the last couple days from colleagues and friends. It is difficult, and I think just as you said, if you had Omicron and you were vaccinated and updated, you can probably wait 3 or 4 months before you get another dose of vaccine. If it is just 4 months out, we know you are protected. We know that there is circulation of the virus still, but there isn't a great surge as there was. So do you want to wait a little bit? You really have to judge your risk. Are you traveling? Are you going to be going to high-risk situations where you're going to be with a lot of people? We know now it's getting into wedding season, graduation parties, prom. Those are going to be high-risk situations, especially indoors. Are you going to try and protect yourself when you get into those situations? If that's true and you are more than 4 months out, you might want to get a dose of the vaccine 10 to 14 days before that. Again, there is still unanswered questions. We know that experts are debating back and forth. Population-wise, we know the vaccines, if you had your up-to-date booster, you are still protected maybe 70 to 75% from going to the hospital. But if you get that booster, you are probably protected 85 to 90% from going to the hospital. And some people say, well, after that third dose, you're okay. But on an individual level, if you want to reduce your risk even further for going to the hospital and going to the ICU, I think that's a reasonable thing to do. Again, me and you, Steve, seeing that every day in the hospital, seeing people who come to the hospital, I think you should be able to do anything you can to reduce your risk as much as possible.
Absolutely.
Cindy, I hope that answered your question. So in a nutshell, doctors are okay with mixing at this point. She wants to know what.
Yes.
Definitely
Definitely okay.
Okay.
But I wouldn't go from an mRNA to a J&J.
Okay.
If you're gotten mRNA, stay with it.
Stay with it. Gotcha.
Yeah.
Okay. All right. Thank you for your great questions today from our community. All right. Let's get to our final thoughts from everyone. Dr. Drake, I think I'll start with you. You're brand new to the health system. We're just really glad to have you. You're so new that this is the first time you met Dr. Stites.
That's right.
Dr. Hawkinson.
Yeah.
So
Yep.
glad to have you on the team, and please come back at any old time. Final thoughts today.
I just want to thank you for having me on and giving me the opportunity to share my experiences, and I hope it was helpful.
It was very helpful. Thank you so much. Dr. Ford, thank you so much for sharing. Again, we appreciate you always. Just your final thoughts?
Final thoughts are really, just be supportive of colleagues and family and friends at this time, because we don't know when our last day is here. So make every day count.
Really well said. Thank you. And please send all of our best to your family. We really appreciate them as well. Thank you. Dr. Hawkinson, let's go to you next. It's you.
Great questions. I know there will be more questions about boosters. Again, it's going to be safe. Judge your risk. Talk with your medical team. Talk with your physician about when should you get that booster dose. The most important thing is to remain up to date with your vaccinations to help reduce your chance of going to the hospital, going to the ICU, and of course dying, and we know that these vaccines do that very well.
You never have a final thought, but what's your kind of semi-final thought today?
I always have another thought. How
you
about
do,
that?
you do.
As long as I can actually still talk, which is sometimes a challenge. So here's what I know. When we deal in science and we try to deal in truth, we can solve problems. And I think in humanity, when we don't have an honest, truthful conversation, we end up in situations like Ukraine. Because if we can try to take care of each other, one of the greatest moral obligations we have, taking care of each other, then we don't have to see war. But what we see instead is in the midst of the war, we still see people taking care of each other. So Dr. Drake, thank you for your service, whether it's in the Middle East, Ukraine, or wherever it has been. And the Dr. Deetra Ford, thank you for talking about your personal story, and good luck with your family. May Godspeed.
All right, great discussion, great panel today. Thanks to everyone. From one great discussion to another. Coming up at 10 a.m., it's a new episode of All Things Heart. Our host, Alexis Del Cid, she is joining us now with a look ahead. Another fascinating story on deck, it sounds like it, Alexis. Good morning.
This one is so compelling. You're about to meet a man who missed all the signs that his heart was failing. His name is Garen. He's the first to admit he was in denial. But why wouldn't he be? He was 40, in great physical condition. He was incredibly active. He thought everything was great. So when his smartwatch told him something was wrong, he says he thought the watch was broken and he took it off. The rest of Garen's family, however, was not in denial.
I kept telling him, you need to go see your doctor. There's no reason not to go see a doctor.
Wait till you see how the busy father of 3 finally learned he was incredibly close to dying. You're also going to meet the cardiothoracic surgeon who saved Garen's life, and you're going to learn how he was able to keep Garen's heart pumping until he get a new one. This is a fascinating story coming up at 10 a.m. on All Things Heart today, so bring your questions.
Alexis, my smartwatch is at the bottom of my purse as we speak.
Did you think it was malfunctioning? Or did
No,
you
I just
not
don't have it on.
wear
But
it
I'm going to go charge it up, and it's going back
Get
on
it
my
out,
wrist.
put it on. This will make
I
you want to
will.
wear that watch.
We will be watching. Thanks so much. And thanks, everyone, for joining us today. Don't forget, you can catch our show anytime on Facebook, YouTube, and, of course, now on Twitter. Coming up tomorrow, the future is here when it comes to cancer treatment. In just 1 month, our new Proton Center will open at the University of Kansas Health System. That means patients and families will not have to travel hundreds of miles away for this life-saving cancer therapy. The final phase before the grand opening, we are live inside and out of the Proton Center tomorrow at 8. We'll see you then.
Subscribe to our morning medical update and open mics with Dr. Stites podcast. Now, everywhere podcasts are available.